The topic for discussion is cementum. Cementum is a calcified, avascular mesenchymal tissue that forms the outer covering of the anatomic root. We already have seen that cementum is one of the hard tissue component of the periodontium. It forms the outer covering of the anatomic root. You can notice in the picture the yellow colored lining around the root surface. The cementum lacks luster. It is of darker hue when compared to enamel and it is light yellow in color. The cementum is derived from a Latin term cementum, which means the chips of stone used for making mortar. So it's a bone-like tissue, it does not undergo remodeling, but it increases in thickness throughout the life. Next, we will be seeing the types of cementum. Based on the cellularity, the cementum is classified into two types. Those are the acellular cementum and the cellular cementum. As the name suggests, the acellular cementum does not have any cells. It is acellular, whereas the cellular cementum contains cells. The acellular cementum is formed before the tooth reaches the occlusal plane and it is the first formed cementum. Therefore, it is also called as primary cementum. Whereas the cellular cementum forms after the tooth reaches the occlusal plane and it is formed after the acellular cementum is formed. Therefore, it is a secondary cementum. And the thickness of the acellular cementum ranges in between 30 to 230 micrometer. Another important point is that the acellular cementum will have the most amount of Sharpie's fibers. So the Sharpie's fibers, we already know that Sharpie's fibers are the extrinsic fibers. They are the portions of the principal fibers of the periodontal ligament that get embedded in the cementum and the alveolar bone. So the acellular cementum has Sharpie's fibers in most amount when compared to the cellular cementum. The acellular cementum is more calcified when compared to the cellular cementum. In this diagram, you can see that the cellular cementum is containing the cells, that is the cementoblast, whereas the acellular cementum is not having the cells. And there are more amount of fibers in the acellular cementum, whereas the cellular cementum has less amount of fibers, right? Next, we go into the Schroeder's classification. Before learning about the Schroeder's classification of cementum, I want you all to understand two important terminologies. The first one is extrinsic fiber, second one is the intrinsic fiber. The extrinsic fibers are the Sharpie's fibers. These Sharpie's fibers are the terminal portions of the principal fibers of the periodontal ligament that get embedded into the cementum and alveolar bone. You can notice in the picture that the terminal portions that are getting embedded into the bone and cementum are labeled as the Sharpie's fibers. So these Sharpie's fibers are formed by the fibroblast, whereas the intrinsic fibers are those that are formed by the cementoblast. These intrinsic fibers belong to the cementum matrix. With this knowledge, we will move into the Schroeder's classification. The first one is the acellular afibrillar cementum. All the descriptions for these types of cementum lie in the name itself. So it is acellular, it does not have any cells. It is afibrillar, it does not have any fibers, neither extrinsic fibers nor intrinsic fibers. It is found as a coronal cementum and its thickness ranges from 1 to 15 micrometer. Next one is acellular extrinsic fiber cementum. It does not have cells but it has extrinsic fibers, that is the Sharpie's fibers, and it is found in the cervical third of the roots. Its thickness is in between 30 to 230 micrometer. The third variety is the cellular mixed stratified cementum. This is composed of mixed here. It is composed of intrinsic as well as the extrinsic fibers. It is found in the apical third of the roots and in the furcation areas. Its thickness ranges from 100 to 1000 micrometer. Next one is the cellular intrinsic fiber cementum. It contains cells, it contains intrinsic fibers, but it does not contain extrinsic fibers. Another important point here is another term called as intermediate cementum was also given by Schroeder. But before learning that, let's see this diagram. Here you see the acellular extrinsic fiber cementum wherein there are no cells and only extrinsic fibers are seen. The next one is cellular intrinsic fiber cementum, wherein you see the cementoblast lying in between the fibers and there are intrinsic fibers only. The next one is the cellular mixed stratified cementum, wherein you have the intrinsic fibers, extrinsic fibers as well as the cementoblast. Next, I want you all to understand an important terminology called as intermediate cementum. This intermediate cementum is a zone in between the dentine and the cementum. It is a poorly defined zone. This zone, that is the intermediate cementum, it does not resemble dentine, it does not resemble cementum also. It is in between dentine and cementum, but it does not resemble both of these layers. Usually it was believed that this layer was formed because the Hertwig's epithelial root sheath cells got trapped into the matrix. So when the dentine or cementum was forming, either in dentine or in cementum matrix, these cells got trapped when there is rapid deposition of dentine or cementum. So that's why it was thought that this layer is deposited in between the dentine and the cementum. Sometimes this intermediate cementum is present as a continuous layer in between the dentine and cementum, whereas sometimes it is seen only as the isolated areas. So here in the picture you can notice a layer of calcified tissue in between the dentine and the cementum, and it is noted in the apical regions of the tooth, especially apical 2/3 of the roots of molars and premolars, and it is rarely seen in the incisors or the deciduous teeth. Next, we will see the composition of the cementum. The composition includes inorganic components as well as the organic components. The inorganic component is made up of hydroxyapatite crystals, which make up almost 45 to 50% of the composition. This hydroxyapatite content is less than that of the bone, enamel and dentin. These hydroxyapatite crystals are thin and plate-like, and they are similar to those that are seen in the bone, and they are arranged in parallel to the long axis of the collagen fibrils. And other inorganic components include small amounts of fluoride, iron, lead, potassium, silica and sodium. The cementum has highest fluoride component when compared to the other structures, whereas the organic component includes the collagen fibers, glycoproteins. Mainly type 1 and type 3 collagen are seen in the cementum. And there are some proteins called as bone sialoprotein and osteopontin, which are the non-collagenous proteins. So the organic component includes the collagen fibers as well as the non-collagen proteins. So next we will learn about the cemento-enamel junction. The junction in between the cementum and the enamel, in between the crown and the root surface, whatever the junction is present, that is called as cemento-enamel junction. Okay, this is of particular importance in case of root planing procedures. And remember the OMG rule. OMG here means the overlapping type of cementum. M means the cementum meets the enamel, whereas G means there is some amount of gap in between the cementum and enamel. In the first picture you can see that there is overlapping in between the enamel and cementum, whereas in the second picture you can see that they are present edge to edge, they are meeting. In the third picture you can see that there is gap in between the cementum and the enamel. In about 60 to 65% of the cases, overlapping type of cemento-enamel junction is present, whereas in about 30% of the cases, edge to edge bud joint exists, whereas in 5 to 10% of the cases, the cementum and enamel fail to meet. Two important clinical implications of the cemento-enamel junction are that the first one is if over-instrumentation is performed during scaling and root planing procedures. If over-instrumentation is done, then it will remove the layer of cementum, resulting in the dentinal hypersensitivity. Once the cementum is removed, the dentin gets exposed, because of which hypersensitivity is seen. Another important thing is that in the third variety, in the OMG rule, the last variety is the gap in between the enamel and the cementum. In this case, if suppose a gingival recession takes place, if the gingiva migrates apically, since there is no junction in between the cementum and the enamel, this place where the gap is present will be directly exposing the dentin to the oral cavity. Therefore, again the hypersensitivity will be seen. The next concept is about the cemento-dentinal junction. It is a junction in between the cementum and the dentin. So, the area where the cementum joins the internal root canal dentin is called as cemento-dentinal junction. An important clinical implication is that during the root canal procedures, the obturating material should always end at the CDJ, that is the cemento-dentinal junction. And with age, there won't be any dimensional change in the width of the cemento-dentinal junction. It wouldn't increase, it wouldn't decrease, it will always be stable. Next, we will learn about the thickness of the cementum. In the introductory slide itself, I told that cementum increases in thickness throughout the life. So cementum deposition is a continuous process and it progresses throughout the life. So the cementum formation is most rapid in the apical regions. So its thickness in the coronal region is 16 to 60 micrometer, whereas in the apical region it is 150 to 200 micrometer. So why does the cementum continuously become deposited? The cementum formation compensates for the tooth eruption. Whenever there is attrition of the teeth, the tooth tries to meet its opposing tooth. When it tries to make the occlusal contact with the opposing tooth, the tooth tries to erupt. Then in that cases, in order to compensate this attrition, in order to compensate for the tooth eruption, the cementum gets deposited apically. That's why there is more rapid formation of the cementum in the apical regions, and this deposition of the cementum compensates for the tooth eruption that is taking place. And the cementum is thicker in the distal surfaces when compared to the mesial surfaces. The reason behind this is because of the functional stimulation from the mesial drift, there will be more deposition of the cementum on the distal surfaces, and there are abnormalities in the thickness of the cementum seen. That is because of the absence of the cellular cementum or because of the excessive deposition of the cementum. Absence of cementum occurs in cases of cemental aplasia or hypoplasia, that is less deposition or complete absence of the cementum, whereas the cementum hyperdeposition is caused by cementum hyperplasia or hypercementosis. Next, we will learn about the cementum resorption and repair. As we already know that the physiological resorption process takes place only in the primary teeth, it does not occur in case of permanent teeth. But the cementum of either erupted teeth or unerupted teeth will undergo some amount of resorptive changes, but these resorptive changes are of microscopic proportion. So radiographically also we cannot detect, since they are of very small amount of resorptive changes. And these resorptive changes are also caused by local or systemic conditions. The local conditions include trauma from occlusion, orthodontic movement, and in case of teeth that are present without the functional antagonist, or in case of replanted or transplanted teeth. In case of teeth with periapical disease and periodontal disease, some amount of resorption takes place. Whereas the systemic conditions that cause a cementum resorption include the calcium deficiency, hypothyroidism, and Paget's disease. How do we know that the cementum is resorbing? So if we observe microscopically, the cementum resorption appears as a bay-like concavities, as you can see in the picture, and multinucleated giant cells are present in larger numbers adjacent to the cementum that is undergoing active resorption. So in this way we can detect that the cementum is undergoing resorption. The resorptive process of cementum may even extend into the dentine and pulp, but this process of resorption is usually very painless, and cementum resorption may not be a continuous process. It takes alternate periods of deposition and alternate periods of repair. You can notice in the picture the resorptive lesion and the partial repair that is taking place with the deposition of the cellular cementum. Next, we learn a concept called as ankylosis, the fusion of the cementum and alveolar bone and with the obliteration of the periodontal ligament. So the complete fusion of the cementum and the alveolar bone is called as ankylosis. This usually takes place in teeth with the cemental resorption. These conditions include the chronic periapical inflammation, tooth replantation, and in case of occlusal trauma. This ankylosis results in rapid resorption of the root and also its gradual replacement by the bone tissue. Next, we will see what happens when the cementum is exposed to the oral environment. The cementum becomes exposed to the oral environment in cases of two conditions: when there is gingival recession or when there is loss of attachment in case of pocket formation. The cementum is sufficiently permeable, so it allows the penetration of the organic substances, inorganic ions, and bacteria. So the bacterial invasion of the cementum again results in the periodontal disease. So these two conditions are very important in which the cementum gets exposed to the oral cavity. Now we come to the conclusion of the topic. Cementum, because of its structural dynamic qualities, is able to provide the tooth attachment. It's one of the component of the periodontium. It helps in maintaining the occlusal relationship. So the extrinsic fibers and intrinsic fibers in the cementum help in the tooth anchorage. The irreversible damage occurs to the cementum when the cementum gets exposed to the environment, oral environment, due to a pocket or loss of attachment. The important questions from this topic are the types of cementum, especially the Schroeder's classification of the cementum and the cemento-enamel junction types. You need to remember the percentages of these OMG types. The OMG rule is very, very important. And also in case of the Schroeder's classification, the thickness of each type of cementum has to be remembered. And the composition of the cementum is also very important. So the types, composition and the cemento-enamel junction are very important questions from this topic. Thank you everyone for your patient listening, and all the best.